Hi, everybody. Welcome to ACHQC Core Insights. Thank you all for joining. We have an awesome program set up for tonight. We have Dr. Jake Greenberg from University of Wisconsin here moderating our session, and Dr. Luciano Tastaldi, who's a resident at UTMB in Galveston, will be reviewing ab wall anatomy and really kind of getting into the details for us and applying it for us with some cases. And we're going to talk to the expert about the cases. And then Dr. Sam Zolin, who's a Cleveland Clinic resident, will go through a couple of articles for us. So thanks again for joining. And Luciano, I'll let you kick it off.
Great. Okay, so I'm going to take it away. I'm going to start with the educational part of the session. We have a tight schedule, so I'm going to try to make this really short and sweet so we can spend more time on the cases and make this really interactive, okay? I have no disclosures related to this talk. None of the material that I'm showing here is original. I use a lot of the Ethics of Abdominal Wall Reconstruction, the hernia surgery book. There's Dr. Rosen's talk, which is available on the America's Hernia Society website. And those two videos, I would like to thank Dr. Muissens and Dr. Renard and Dr. Beliansky. Those two videos are available on YouTube. They're a very nice overview of abdominal wall anatomy to what it relates to abdominal wall reconstruction. So most of the material is from here. And I suggest for the residents and fellows on the call to take a look specifically at those videos later. Very good material, okay? So the objective of my talk is trying to discuss the backbone of the modern hernia repair, because with the advent of the techniques for component separation, at least the way I see it, it's a way for you to communicate several spaces within the abdominal wall. So I'm showing here on the first slide, right at the midline, the first space is the falciform ligament in a preperitoneal position, and down there, also in a preperitoneal position below the umbilical ligaments in the urinary bladder. That's when you do a midline incision, you open the fascia, that's the first thing that you're gonna encounter. When you start going to do your retrorectus dissection, then you incise the posterior rectus sheath and you dissect the retrorectus space on both sides, and then now you're able to communicate the preperitoneal plane on the midline and the posterior, the retrorectus space on bilateral sides. And if the hernia that you're treating is necessary, a larger advancement, you get access into the pretransversalis / preperitoneal place into the lateral abdominal wall. So the backbone of modern hernia repair is having the ability to communicate all of those spaces and create a nice pocket in the sublate position for your mesh. And with that communication of spaces, having enough advancement to close the defect. So breaking down the anatomy in three major topics, the musculofacial components, the innervation, and blood supply. I'm going to go over that real quick, considering who our audience is. On the midline, we have both rectus abdominis muscles. They're originating on the pubic crest and symphysis, and they're going to insert here on the xiphoid and the anterior surface from the 5th to the 7th costal cartilages. The main function of the rectus abdominis is to flex the abdominal wall and to perform forceful exhalation and assist in defecation, any of the situations where you need an increase in the intra-abdominal pressure. And it also stabilizes the pelvis while walking. When we go to the lateral aspect of the abdominal wall, from superficial to deep, we have the external oblique, which is the hands on the pocket muscle, has this inferior-medial orientation, originates from the 5th to the 12th rib on the anterior aspect, and it's going to insert into the iliac crest, into this symphysis pubis, and into the linea alba. And this fold here is going to form the inguinal ligament. Down to the deep to the external oblique muscle, we have the internal oblique muscle, which has an orientation that is from down up. It originates from the thoracolumbar fascia and is going to insert from the 10th to the 12th rib. And I think the most important one, and we're going to spend more time discussing, given this importance in the surgical techniques, is transversus abdominis, which has this transverse orientation, is the deeper of those muscles. It originates from the iliac crest, the inner surface of the 12th rib, and also some interdigitating fibers of the diaphragm, which I'm going to talk about. And it's going to insert into the linea alba and into the pubic crest, where it's going to form the conjoint tendon together with the internal oblique muscle. Also important to mention a couple of lines into the abdominal wall, and not only the muscles, where the anterior rectus sheath joins into the midline. That's where we find the linea alba here, and that's exactly what's the name, why the name is linea alba. It's because it's white. So it's the joining of the anterior rectus sheath on both sides into the midline. The linea semilunaris, it's well known to cause a lot of problems if you do not pay attention to it during your dissection. And I think this picture here explains very well why it's important for you to dissect and understand the landmarks to identify the linea semilunaris, because you cannot really see it. This is a picture of an external oblique release, where for you to know exactly where to cut and perform your external oblique release or your anterior component separation, you have to do really this bimanual palpation, so you can feel the lateral edge of the rectus muscle, and then you're going to be doing your incision about 1 centimeter laterally to that. So then you can get into the correct plane. After you do that incision, this is the external oblique, this is the internal oblique, you get into this avascular plane in between those two, and you're able to do your anterior component separation. Here another picture, external oblique here on the left picture, on the left side, and then the external oblique has been lateralized, and now we see here the internal oblique with its fibers going up. Okay, arcuate line, another very important anatomic structure that we need to recognize. This is where the aponeurosis of the external oblique, internal oblique, and transversus abdominis is going to fuse together here into the lateral aspect of the rectus muscle. And I think very important to know also who's going to form the anterior and the posterior rectus sheath, because this is going to be different when you're talking above the arcuate line and when you're talking below the arcuate line. Above the arcuate line, anterior rectus sheath is going to be a combination of the external oblique and an internal oblique, which is going to form the anterior lamella. And then you have a posterior lamella of the internal oblique, which is going to be fused into the transversalis fascia. And that's why this is a very important anatomic landmark for our posterior component separation, which I'm going to talk about. Below the arcuate line, actually the transversus abdominis and the internal oblique are going to be giving contributions to the anterior rectus sheath, and we do not have a posterior rectus sheath. We only have the fascia transversalis. Here, a very nice view of the arcuate line. You can clearly see the transition here between the posterior rectus sheath. The arcuate line is here, and there's only transversalis fascia below. And here, a view from inside the abdomen, where you can see the arcuate line and you can see the inferior epigastrix going up. I think this is a very nice demonstration from this video from Dr. Beliansky that shows the contribution of the transversus abdominis muscle to the posterior rectus sheath, which is different according to which part of the abdominal wall you are, either on the upper third, middle third, or posterior third. So we have here our linea semilunaris, as we can see, is not a straight line. It changes according to where you are in the abdomen. The arcuate line that we just spoke about. We have our posterior rectus sheath, which is the posterior lamella of the internal oblique. And we can see here that on the upper abdomen, the transversus abdominis muscles, it extends into the midline and gives actually a muscular contribution to the posterior rectus sheath. And then it starts to getting retracted laterally. And then on the middle third and on the lateral third, it's actually an aponeurotic contribution and not a muscular contribution. So whenever we perform our posterior component separation, upon incising the posterior lamella of the internal oblique, which is going to be medial to the linea semilunaris, we're going to encounter the fibers, the muscular fibers here on the upper abdomen, but we're not going to find that on the lower abdomen. We can see here very clearly on this picture, inside posterior lamella of the internal oblique is incised. We see the muscle fibers in here. As we go down, we don't have any muscle fibers. The transversus abdominis is mainly aponeurotic. And then another good picture in here where we can see head up, feet down, posterior lamella of the internal oblique. We have the transversus abdominis fibers here that are being cut, this aponeurotic contribution. And when we get here below the arcuate line, there's really only transversalis fascia. We extend our dissection then into the pre-transversalis / pre-peritoneal plane into the lateral abdominal wall, and we can get down all the way to the retroperitoneal and find the psoas muscle. This is the key tenet for the posterior component separation. As I mentioned initially, that the moderate hernia repair is the ability to communicate all those planes. When we're thinking about the most cranial aspect of our dissection, we can see here the communication of the right posterior rectus space and the retrorectus space on the left side, the falciform preperitoneal space on the midline, and then we extend our dissection more into the lateral aspect, and that's when we start having the contribution of the fibers of the diaphragm to the posterior rectus sheath and to the transversus abdominis. We see that there's a different orientation of the fibers here on this aspect. This is because this is diaphragm, is not transversus abdominis anymore. And when we extend our dissection in the preperitoneal, retromuscular, retroperitoneal, we can create a nice pocket that is above the costal margin to place our mesh, another important aspect. And last is getting this dissection into the pelvis, into this preperitoneal space, where in the center, we get into the space of Retzius, which is the retrovesical space. You're gonna be getting in front of the bladder, sweeping the bladder down, and into the lateral aspect of the abdominal wall, exposing also the spaces of Bogros laterally. Next important topic, and I think I cannot stress that enough, it's very important to understand the innervation of the rectus muscle into the abdominal wall, because you need to recognize those structures during your dissection to avoid iatrogenic injury. The rectus muscles is innervated from fibers from T7 to T11 in a segmental manner, as we can see here, and those fibers are gonna be traveling in between the internal oblique and the transversus abdominis muscle. They're gonna perforate the posterior lamella of the internal oblique, and they're gonna be innervating here the rectus muscle. Here, I think it's very important to see both on a robotic and an open approach. They're gonna mark the lateral extent of your dissection, and we can see here the neurovascular bundles on both of the pictures. So I have a faculty here that says that this loose alveolar tissue plane here is God's way of telling you where to cut, but that's a specific scenario where the neurovascular bundles are the God's way of telling you exactly where not to cut. Not only because you're gonna denervate the rectus muscle, but because if you continue more laterally, you're gonna injure the linea semilunaris. And last, the vascularization and the blood supply to the abdominal wall, it's divided according to the, namely, Hugger zones. Zone 1 is the central part of the abdomen, which is going to be a combination of the superior epigastric artery, which is an end branch of the internal thoracic or the mammary, and the inferior epigastric artery, which is a branch from the external iliac. Important to say here that the inferior epigastric is dominant. Okay. On the zone 2, which is the bilateral lower abdominal wall, we're going to have the epigastric arcade, the superficial inferior epigastric, the superficial circumflex artery, and the superficial external pudendal artery. All of those arteries are going to give your vascularization to this area. And last, into the lateral abdominal wall, you're going to have a contribution of the musculophrenic, lower intercostal, and lumbar arteries, which are going to be also traveling in the transversus abdominis plane. Another important aspect of the blood supply to the abdominal wall is recognizing where the perforators are, the periumbilical perforators. So we know that 5 centimeters above, 5 centimeters below the umbilicus is where the majority of those branches from the inferior epigastric are going to be perforating the rectus and are going to be giving blood supply to the medial aspect of the skin. And why this is important? We want to try to avoid undermining the skin and the subcutaneous tissue in this area, because in some patients, it can lead to flap necrosis. So the perforator sparing anterior component separation was developed thinking about that, where you create your subcutaneous flaps and you preserve that 5 centimeters above and below the umbilicus, so you do not kill those perforators. and you decrease your odds of having skin and flap necrosis. Okay, I think that the take-home message of all of that is I learned from Mike Rosen when I was back there doing my research fellowship, is that it doesn't matter, I think, that whatever technique, whatever mesh you're doing, I think the most important thing that is going to predict the outcome of your hernia repair is really understanding the anatomy. And whenever you're doing your dissection, respect those tissue planes, the blood supply, and the innervation. No matter what technique you're doing, if you really understand these concepts of the anatomy, you're probably going to be prone to a good outcome for your patient. That was the educational part that I had, and gonna follow now with the second part, which is a little bit of cases. We would like to make this pretty interactive, get the participation of the faculty that are involved. I have 3 cases here, and I would like to get Kayla to help me to assign those cases, and also Dr. Greenberg to get some of the people participating and discussing those cases. So the first one, this is thanks to Dr. Sergio Raul, who provided this case to me. This is a male that presented to clinic with an enlarging painful bulge on the flank on the right side. It had a history of a blunt abdominal trauma and presented with this bulge on the right side. We can see here the CT scan. There's a clear defect here on his lateral abdominal wall. Couple of cuts, some other cuts, and this is a 3D reconstruction of what the defect is. Dr. Greenberg, would you like to start discussing and engaging folks?
Absolutely. So a couple other questions for you first, Luciano. So any other history in the patient? Smoker, diabetes, BMI looks like it's okay.
Yeah, BMI is 30. He's a non-smoker. No really other comorbidities. He, at that time of the trauma, which was about 6 months prior to the presentation, he just had a liver injury that was managed non-operatively. Never had any prior abdominal operations, and that's it. He's symptomatic. He has pain. He has no obstructive symptoms, and he would like to discuss what are the options for his repair.
All right. Well, I see a couple different faculty members on the webinar, so we'll pick on them. Dr. Perez, I see you back on the second page here. What would you do to approach this?
So a couple different options with this gentleman. I think if he's ready for surgery, it sounds like he's like 6 months out from his car crash, and he's healed up from all other injuries from the car crash itself.
Yes, ma'am.
Okay. So I would probably attempt to actually try and do this robotically. I think flank hernias are pretty nice to try and do robotically, and kind of a minimally invasive repair. Try and go in, dock, and do almost a pre-peritoneal repair, and just do a tap robotic repair.
All right. Dr. Prabhu, what would you do?
I'll be honest, for this kind of thing. Can you hear me okay?
Yes.
Okay. For this type of defect, I actually really like to do this open, because I think in this case, given that the iliac crest is right there, and given that the guy is a little overweight, I'm inclined to use bone anchors for this situation. So I do an open flank incision.
And do you want to describe how you would place those for those that have never had the fun and opportunity of wielding power tools in the OR?
Sure. So basically, you've got to have the patient in lateral decubitus position on a beanbag. You want to have their belly button lined up with the break of the bed. You want to break the bed, flex them, have an axe roll, and obviously appropriate padding. And then that'll open up that space between the costal margin and the ASIS, or the iliac crest. And I'd make my incision right over that. I would also get into the retroperitoneal plane, dissect all the way back out to psoas. And then as you come along medially, I would clear off an area on the iliac crest, and you want to make sure you have kind of good, healthy bone there, and that you have all the muscular tissue, whatever remnants of muscle are on there, you want to dissect that off so that you have kind of a flat landing zone. And then you would use a MyTech bone anchor, which comes along. There's a drill that normally our orthopedic friends will use, and it's essentially like a molly bolt that you put at a 90-degree angle to that iliac crest, and you essentially put a hole right in there, and then you stick the molly bolt in there, and you have to give it a little tap with, there's usually a mallet that comes with that, but I'll often just use the back of the drill. And then that will release the bone anchor sutures into the bone, and they have these little spikes that come out of it like a molly bolt. And then there are usually 2 full sutures on there, and you end up cutting one off, and then you can just pass the needle through the mesh and tie it down that way.
Awesome. I have no idea how to do stuff around the house, and that's about as handsy as I get in putting in molly bolts, because I never do it at home, just on patients. Dr. Rosen, what would you do?
I don't think I have much to add for this. I mean, my first question nobody really asked is, like, I don't speak Portuguese, so Luciano, what did that tattoo mean? That's going to guide my treatment options. I know that Ariel is very concerned about the scars when this guy's like covered in tattoos. So what does that tattoo actually mean?
I think it's
here?
like, yeah, I think it's like loyalty and faith or something like that.
All right, good. I just want to know what I'm dealing with. So listen, to be fair, I think doing these things lap robotic is totally fine. It's super far lateral. It's kind of a preperitoneal dissection. Nothing wrong with that. I think, to be fair, like even open, you're unlikely to get this thing closed. You're going to be right up on the edge. So this would be kind of a no close situation for me, which I don't think is that big of a deal. And then I would do it the way Ajita described. Maybe like a couple other things that I would just kind of add to that is, I think MyTech bone anchors are totally fine, and it's something to have in your wheelhouse. I might just, one little word of caution about them is that you're drilling into the bone with a permanent material, and it's a braided polyester permanent suture. So if you get an infection, or if it happened to be a contaminated case because of enterotomy or something, that would be very ill-advised, because that's going to give you osteo, and you're going to have to go back and core those out with the orthopedic surgeons and take all that hardware out. So I use them. I think in this case, it'd be like plus minus. The only reason I think maybe you don't need it is if you look, even though it's right up to iliac crest, if you use your medial border of the psoas as your dissection, it looks to me like you probably have enough coverage. But I don't think there's anything wrong with doing it. I think it's I will do it a couple times a year now just to kind of show the fellows how to do it, but I do it much less frequently than I used to, just because I think overlap is probably a little bit more important than the MyTech bone anchors. But I got nothing wrong with that. You can do that. One last thing I'll just say is Alfie Carpenter has shown how to do that, both laparoscopically, and I'm sure you can do it robotically too. So it doesn't preclude.
Could you just repeat the part where you said I would do what Ajita said to do?
That's my normal tagline. I would do what Ajita said, but 5 things differently. And then my last comment, just real quick, because nobody mentioned this. I think if you look at this scan, I would be prepared, and this may be where I would like question the robotic stuff, is if you look at the kind of medial border of the hernia, okay? You see how it kind of comes, it's like midway through the oblique muscles. If you measure the distance of that to the linea sublunaris, it's probably like 7 or 8 centimeters maybe. You're going to be getting really close to where that might not be enough overlap, or you might not be able to get the posterior sheath back together, the peritoneum back together. And so this is just one spot where, like, just kind of like some people call it a reverse tar, or using the retrorectus plane is something that I would think about in this guy. He looks like a super active, otherwise functional person. So I'd want to kind of cover his whole abdomen, but it would take a bigger incision than just doing this preperitoneally. But most of the time, these flank incisions don't really hurt. So I wouldn't be afraid to put a whack on this guy if I wanted to.
Yeah. Another option, kind of robotically, is you could do an E-tap on that ipsilateral rectus and then kind of tar over on that side. If the coverage, when you kind of measured it out, didn't seem like you would have enough medial coverage just by doing a tap repair.
So you would place the patient in lateral decubitus and do an E-tap access potentially?
Correct. It would depend on what the measurements kind of looked at on each kind of section to make sure that you have a wide enough rectus muscle. But you could do an E-tap on that ipsilateral rectus and then tar out laterally on that side, and then just stay into your tar and preperitoneal plane to be able to repair it if there is concern about having coverage.
Gotcha.
I think obviously, not surprisingly, you're hearing a lot of different options for repair of this, which is probably going to be what we'll hear about and see for all of these cases. But I agree with what everyone said. I mean, I think that you have options here in this patient, and I think Dr. Rosen's point, if those tattoos are particularly important and you do this in a minimally invasive fashion, you might be able to avoid them completely. And if he's not completely wedded to them, then you can certainly cut right through them or cut down over that incision on the flank. So definitely some good options. So Luciano, do you want to move on to
Yes,
next case?
correct. Case 2 here. This I would like to specifically engage Dr. Rosen. I'd like to him take a look at this and tell us exactly what he thinks it happens with regards to the anatomy of this patient. So this is a 52-year-old man, came to the ED with a small bowel obstruction. His history, he had a midline incision for an splenectomy due to a car crash in the 2000s. It was complicated by an incisional hernia that was fixed laparoscopically through an iPhone approach in 2005, recurred. And then what we know when he presented is that he got this hernia fixed through an open approach with a reconstruction of his abdominal wall, that was his own words, with mesh. And what he tells us is that this lateral bulge that we see here happened about 3 months after the operation. He was asymptomatic from it, took a while to recover from the first operation because he had an ileus, was not really bothered by it other than the cosmetic discomfort of the bulge. But then he presented with a small bowel obstruction. That's a quick video of his CT scan. Gonna put it again real quick so everyone can see the details. I would like to get Dr. Petro and Dr. Rosen involved to discuss, number one, what happened on the anatomy in here, and number two, how would they fix that?
Well, I think this is really important because we made a video about this and submitted to YouTube. It's called Tar Gone Wild. And so it's available for viewing anytime you guys want to check it out. So this is a great video. I think I remember this case. I think you sent me this and I looked at it. I said, what happened? So a couple things. This is a video of a complete anatomic destruction of the abdominal wall. And it's beautiful because it kind of shows everything that Luciano said, that if you kind of disrespect it, this is what happens. So let's start at the top. Let's go to the very top. I'm going to kind of go down this one by one. So yeah, so go down slow. So right, go a little bit more. So right there. So if you stop it right there, what you see is you see the costal margin and the rectus muscle. And those two things have been completely separated. And so if you remember what Luciano said, which is really important, is the transversus abdominis inserts into the diaphragm. So that's actually still intact here. But the external oblique and internal oblique have been taken off of their insertion, which means that almost for sure, this surgeon got, I think as we go on, we'll see it more, in between the external and I'm sorry, the internal oblique and the transversus abdominis, and you'll see the external oblique will still be there. And the other feature, what happens when you do that is if you look at both rectus muscles, they're both denervated. And you'll see how thin they are after this operation. And as we watch when you go down, the other thing that we've learned is that when you don't actually do a TAR, the one thing that the TAR probably does, the transversus abdominis release, is it allows the posterior sheath to come back together without tension. So keep going down a little more. So that's a hernia through the linea seminaris on the patient's left. Keep going down. Keep going down. You can see the mesh on the posterior, on the rectus muscle. If you keep going down, okay, stop right there. So now, if you look over to the right side where those two tacks are, that's actually the posterior rectus sheath that tore off from the other posterior rectus sheath. And that's a posterior rectus sheath breakdown. And the reason that that happens is because when you don't do the TAR, the posterior sheath is under too much tension. So the lesson in this case is if the posterior sheath is not coming together easily, I don't care what hernia you're fixing, you did not do a transversus abdominis release, you're in the wrong plane. So what that also shows me is that on the patient's right side, they probably didn't actually do the TAR. So that's going to be a little bit easier. So let's keep going down a little more. And you can see the rectus muscles are gone. And the final piece I would just say about this is if you look, this is everything that's wrong with retromuscular surgery in today's world. Is you have now created, you don't have a midline defect anymore, and you have completely destabilized the whole lateral abdominal wall based on lack of anatomic dissection. So Clayton knows how to fix this better than anybody. I think Clayton's got a lot of tricks and tips, and this is really something that he's really grown accustomed to and love. So I think maybe Clayton will take you through the repair, because I'm getting too old to do these. I just can read the CT scans. I can't really tell you. But anyways, this patient had a TAR.
Clayton, what would you do to fix this?
So, there's redo TAR, there's different flavors of redo TARs. And, the redo TAR where someone actually got in the wrong plane, even though it's a devastating complication and you've divided the semilunar line and destabilized someone's core, in terms of redoing the dissection, it's actually not the worst because they never actually ended up in the right preperitoneal plane on the left side. So essentially what you have to do, the right side would be probably end up being a normal TAR. They probably did the retrorectus part, but the TAR component, it'll be challenging, but it'll be doable. On the left side, you essentially want to get into the preperitoneal plane in the subxiphoid space, and then in the space of Retzius. And you want to work your way straight into the preperitoneal plane from the space of Retzius, going right down toward the psoas. And then what you do is you get in the preperitoneal plane laterally and you peel it back toward yourself as medial as you can. And then you just, you divide it as medial as you can. You're not going to have a traditional TAR on that side where you go retrorectus and then you're dividing to get into the preperitoneal plane. So you're starting lateral and you're peeling it back toward yourself. And then you get as much advancement as you can. There's probably a good chance, you're going to have a big gap in your posterior sheath because you're going to lose some of the posterior rectus sheath on both sides. So this is probably a high chance of needing either omentum or vicryl to bridge the posterior sheath. And then, in terms of, you can be obviously a big piece of mesh, and then you're still going to want to close that lateral defect, even though you'll end up going through the midline. So I don't think any other questions about that? Anything I missed, Mike?
I think probably the most important thing is a really honest discussion with the patient that, the rectus muscles have been denervated. So these people are not going to have a normal abdominal wall. We published a little bit on this, and the outcomes for this operation, in fact, Sam Zolin, I think, is one of the lead authors on it, but the outcomes for this are poor. It's kind of a salvage operation. It's doable. But at the end of the day, you have a denervated rectus muscle, and this would be one I would strongly consider heavyweight mesh. But otherwise, this is becoming one of the more common operations that we do, just due to kind of mishaps. But I think the most important thing is, I just kind of, for the point of the anatomy today, and Ben Miller is doing a lot of work on this, is I would just stress, you really ought to have a clear understanding of the anatomic planes that you are dissecting and the expected outcome from each one of those releases. And when you don't see that outcome that you're expecting, kind of reorient, because anybody who's done retromuscular surgery, I have cut the linea semilunaris more than once, but the hope is that you just recognize it, get back in the plane, fix it, and cover it with mesh. So it's not a crime to be in the wrong plane. It's a crime to not recognize it, get reoriented. And my big points would be, just briefly, the anterior, Ben submitted a thing to the AHS for this, which will hopefully come out, but we've looked at all the tension releases in this. And just to stress kind of what Luciano said, the anterior fascia advances primarily with the posterior rectus sheath release and a little bit with the posterior mal, the internal oblique, but the TAR does nothing for that. But the posterior elements really come together primarily due to the posterior rectus sheath release and mostly due to the TAR. So the one thing the TAR is good for is the posterior sheath will always close. And if that's not happening in the OR, take a minute and figure out, did you really do the TAR? And I think it's easy to get lost.
I mean, we see, we all see these complications now, and this is like one of the times that when you see it, you just kind of think like, thank God that wasn't me, right? That I didn't do that by accident, because even with a high volume of these, it can still get confusing sometimes, and they're always challenging cases. And so I think it's important for people to have opportunities like this to talk through these types of cases, understand where problems are, and how to address them, and more importantly, how to avoid them. And I think significant knowledge of the anatomy and the steps of the procedure are key to that. So I think it's great that we're taking time to go through that today. Should we go on to case number 3 in the interest of time?
Yes, for the sake of time, we're gonna try to go a little faster on this one so Sam can have time to discuss. This is a male patient with several prior abdominal operations, both through subcostal, midline, paramedian incisions, and allegedly already got a TAR in the past and now has a recurrent hernia. So the focus here is to discuss what approach everyone will take in here, considering that those subcostal incisions, median incisions already took down a lot of the blood supply to the skin, and what are the options that we have for a patient that already recurred after a TAR, and we don't want to cause more harm and have a skin necrosis after. This is the CT scan. You want to comment on that, Dr. Greenberg?
Yeah, so I mean, in looking at that, so there's pretty significant atrophy of the rectus muscle, especially on the right side in the upper abdomen. It does reconstitute lower down, and the left side actually looks fairly normal, which is good. So there's still some stuff to work with, but there is pretty significant loss of the muscle in the upper abdomen, which is not surprising given the fact that you see those 2 different subcostal incisions, and I am sure in whatever they did to get through that they took out the superior epigastrix and cut the blood supply. to that area. But down low, you definitely still have some much better rectus muscle, both on the right and the left side musculature for the most part looks actually fairly normal throughout all of this. And it's really hard to tell. I think it's easier to tell an external oblique component separation on CT scan. Usually you can see that the external oblique is significantly retracted away from the linea simularis. It's much harder to see if people have actually had a TAR. The transversus abdominis muscle on CT's post-TAR doesn't really seem to retract laterally. So you have to take it on faith in reading their out notes that they actually did it. But usually on CT, it's much easier to see an external oblique release rather than a transversus abdominis. And it certainly doesn't look like he's had the external oblique release. So let's see, who haven't we picked on yet? Dr. Parnell, it sounds like you are going to be joining the group in Tennessee and have been working this past year to dealing with, I'm sure, a ton of cases like this. So what would you do?
Yeah, this would be a midline incision and a TAR for me. Like Luciano kind of already pointed out, with those subcostal incisions, it's already taken out your superior epigastric. So doing an anterior component separation would not be wise in this case, because then you'd be taking out your periumbilical perforators and what's left of the blood supply to the lower abdomen. So I think if you were going to try to attempt that, doing some perforator sparing technique as an adjunct would be wise. But for me, after training at Cleveland Clinic, I'm most comfortable with the TAR, and I feel like the TAR would be the best approach to this case.
Dr. Parmar, welcome. Thank you for joining us. Anything that you would do differently? May not have heard. Or Dr. Beffa.
Hey, yeah. So obviously, I think the biggest challenge with this case, I mean, certainly abdominal wall work is going to be extremely challenging just from all the oblique incisions and lack of musculature and all that stuff. And fighting through that's going to be one thing, but you know, the blood flow to the skin needs to be like heavily. That picture that you showed at the beginning of the patient's front abdomen, I think, is going to be the most challenging of this, because Mike always talks about those triangles, and whenever you start to get triangles in the abdomen, you always have to have some named vessel that's supplying those triangles of blood flow. So, you know, doing it through a midline is going to save you, you know, a lot of getting into those, like, you know, perforators like Kayla's talking about, and trying to save all that blood flow to the skin, because you start disrupting that, you're going to get skin necrosis over your, you know, myocutaneous flaps, and it's going to turn really messy quickly. So I think I would do, like Kayla said, a TAR through a midline.
Yeah, it's interesting. There's pretty good data that that paramedians and subcostals, and in fact transverse incisions, are all associated with a lower frequency of incisional hernia formation at those sites. So it's never actually a bad idea to use those types of incisions for primary surgery. It's kind of certainly the paramedian incision is a completely lost art. Like, no one does that anymore. But they actually have a significantly lower rate of incisional hernia formation than midlines, because of all the layers of the abdominal wall that you put back intact when you're done. So it's never a bad idea to utilize them. The unfortunate problem, I think, is, as you see with cases like this, is that when they do form hernias there, your options are a little bit more limited than what we can do when the hernia is directly at the midline, for sure.
One thing I'll add, Kayla, when you're getting started, fight to get that 2019 operative note, because you're, in terms of planning your day, when you get started, you're going to want to know if that's a redo TAR or not.
Got it. Will do.
Yeah, I mean, I would say, like, all the op notes, right? Try and get everything and figure out what has actually been done. And I think it's also puts a lot of onus on us as surgeons to dictate good op notes, right? Like, don't just say mesh was put into the patient. Like, what type of mesh was it? Where is it? How big is it? What'd you put it in with? Like, you have to be very specific, because very likely someone's going to be back there at some point after you. And I think being really specific about what we do in the operating room makes it much easier for the next person up.
Mm-hmm. Yeah. I think an interesting point you brought up, Dr. Greenberg, is how on a CT scan you can more commonly see the external oblique contract after an anterior component separation, but not necessarily after a TAR. Do y'all think that's because we're normally placing mesh next to the transversus and we aren't always putting mesh as an onlay with that external oblique, you know? And like, how do we think that's affecting functionality if the external oblique's retracting, but the transversus is staying in the same spot? You know, do you think that makes a difference on the function? I think it's interesting.
I have no idea why it happens. My reasoning has always been that when you do an external oblique component separation, your external oblique is kind of like a free flap, right? You've taken skin and subcutaneous tissue off of it, and then you've taken external oblique off of the stuff that's underneath. So it's just sitting there sort of in isolation. And then the natural pull of it is towards the back. Whereas with transversus abdominis, you're mobilizing sort of the pretransversalis or the preperitoneal fat and everything, and peritoneum off of it, but you don't actually take it off of the internal oblique on the other side. So it's still kind of stuck to everything. I have no idea if that's actually why it doesn't happen, but Mike Rosen's group sent like a bunch of CT scans around.
Well, hold on just a second. So actually, Jake, I thought you were setting up Kayla. Kayla, you're way too nice. Kayla was actually the fellow who ran that trial.
It was a great trial.
So Kayla, do you believe that Jake could actually tell based on the CT scan, or 21 of his closest friends when reviewing these CT scans could actually figure any of this stuff out? What do you think?
The data would suggest otherwise.
That we all participated in. I think all these scans, if you have the op note and you look at it, you tell the story that you want to tell. I've done a ton of external oblique release, a ton of transversus abdominis. Which is what this shows is, I actually think nothing happens to these muscles. I think this is all about creating spaces. And the reality is most of the release from the fascia comes from posterior rectus sheath and all these things. And all the lateral muscles we're cutting, like we're just kidding ourselves that anything is happening, at least on CT scans. That's what we showed. I think, if you blind people up, it's hard to tell what happened on the scan.
It was an interesting study, and it was fun looking at those scans and trying to figure out what was done, but it was hard.
It's humbling. It's humbling.
Dr. Parmar, you have your hand up.
Oh, hey, Jake. Yeah, I think you had just asked my opinion, and I was trying to chase my toddler around my house. I'm sorry about that.
No worries.
So I was kind of half listening in, but I kind of caught the subcostal incisions and paramedian scars. And I think, as it was already mentioned, in those situations, I really get nervous about skin preservation and how well the skin will heal. So I didn't get a great look at the scan, but I thought this would be a great application of the robot to try and see if I could do a robotar. And, I kind of approach these situations. If you can get one port in, in the left upper quadrant, you kind of have a chance at getting a second port, and then just kind of painfully and slowly making your way through the adhesions. And that's what I would try to approach. I would do anything in my power to avoid doing this open, but I also think that defect is way too large to close robotically. So, ultimately they'd end up with at least a hybrid in my hands.
Perfect, thank you.
Send Zolin now. It's going to follow with the next part of the meeting where we're going to be reviewing a couple of papers.
And Sam, maybe we just pick the first one, whatever you think in terms of timing. We have about 10 minutes left or so. So whatever you think.
Yeah, I think that sounds good. All right, so I'm going to try to feed through this. Screen share is being a little weird. I'm going to review a paper that's kind of pertinent to abdominal wall anatomy. I'm a fourth-year general surgeon resident at the Cleveland Clinic. I have no disclosures. So there are a lot of different component separation techniques that have been developed to address incisional hernias. We've discussed some of them, like external oblique release and TAR. But one question that kind of remains is, what are the quality of life and functional outcomes of abdominal wall reconstruction as we begin to intentionally divide the abdominal wall musculature? Or another way to think about it is, what is the potential donor site morbidity of doing those releases? So the paper that I'm going to discuss is a paper from the Cleveland Clinic from a few years ago. Ivy Haskins was the first author on it. And the question that they were trying to answer was, what is the effect of abdominal wall reconstruction with transversus abdominis release, or TAR, on quality of life and core stability? And they hypothesized that TAR would lead to improved quality of life and would not affect core stability. Reading that, I thought it was kind of interesting because the transversus abdominis, it's considered a primary mediator of core stability, with the overall concept of core stability being the ability of the body to control range of motion of the lumbar, pelvic, and hip units, so that there's no major deformity, neurodeficit, or incapacitating pain. Things like planking and whatnot would be an example of that. So to investigate this, they did a single center prospective observational study. All patients who underwent a TAR at the Cleveland Clinic over a 4-month period in 2016 were eligible. Quality of life and core stability were measured within 30 days prior to surgery, and then again at about 6 months post-surgery. And then pre-op and post-op scores for various measures were compared using paired t-tests. So the study involved both quality of life measures, one of which was the Quebec Back Pain Disability Scale. This is 20 Likert questions that measure functional disability relating to back pain. And that's broken down into 6 categories of activity, which are listed here. It's scored by category and then totaled into a total score from 0 to 100. In this, a higher score is actually worse. And then there's the Hercules Score, which again, most people who are familiar with the ACHQC will be familiar with this, but it's 12 Likert questions that relate to abdominal wall quality of life and function. And it's standardized, so again, to be from 0 to 100. The difference here is that a higher score is actually better. Now, the more functional methods of assessing core stability in the study, they relied on the idea of abdominal wall hollowing, which is described as being simultaneous contraction of the muscles responsible for core stability, including the transversus abdominis. And in essence, this would be to contract and draw in the abdominal wall towards the spine without moving the pelvis. And the device that they used to measure this was a stabilizer pressure biofeedback system, which consists of an air-filled pressure cell that's positioned under the patient. And then changes in pressure with activity indicate whether the patient's able to isolate and maintain contractions of the abdominal core. And this device, it looks like it's available online for about $100 if anyone wants to do these tests themselves. So the first test of core stability was the prone test, and that was having a patient perform abdominal wall hollowing while laying on top of the pressure feedback monitor. The pressure gauge was set to 70 millimeters of mercury, and then hollowing should decrease that by at least several points to below 70. The pressure decrease was recorded, and then patients were instructed to do this a total of 5 times, and then the average was used for analysis. The second measure of core stability that was used in this study was a little more complex. It's called the Sarmin core stability test. And this consists of basically a series of activities that are grouped into levels, of which there are 5. And these are all core exercises that are performed in a supine position. And they involve leg flexion and extension, both to slightly above ground level and at ground level. And the idea is to progress through each level while maintaining a stable core, again, with the pressure monitor under the lumbar region. So to progress, the core stability has to be maintained. The device is set at 40 millimeters of mercury, and it can't change by more than 10 millimeters of mercury from that baseline. So patients were asked to perform that test 5 times, and then the highest level that they were able to achieve was recorded. So a total of 21 patients participated in the study. As you can see, the the sample size is relatively small, so you have some wider standard deviations. On average, patients were older, tended to be obese. In terms of pertinent hernia details, the average hernia width was fairly wide at 18 centimeters, and then the standard deviation of 6. But it is notable that fascial closure was achieved in all patients, and at least a 30 by 30 centimeter piece of permanent synthetic mesh was used for repair. As we look at the postoperative quality of life results, we see, basically for the Quebec Back Pain Disability Scale, in every single one of the subscores, there is improvement from the preoperative to the postoperative score. So the score is getting lower, and all of these changes were statistically significant, including the total score. Hercules mirrored this, where again, the preoperative score had a statistically significant increase to the postoperative score, again, from 38.5 to 61.5, which would indicate improvement in quality of life. When we look at the results of the core stability tests for both the prone test and the Sarmin core stability test, there actually was not any change from preoperative to postoperative, which would suggest that dividing the transversus abdominis muscle in the context of this hernia repair really didn't lead to a measurable change in core stability. So again, 6 months after TAR, there's improvement in back-related functional disability, there's improvement in hernia-related quality of life, but there's not a measurable change in core stability. And so I guess that, trying to reason why that might be, first is that the TAR is performed near the distal insertion of the transversus abdominis, so maybe leaving it mostly intact lessens the effect of it. Another one that's posited by the authors is that reinforcement with mesh allows for tissue ingrowth of the cut muscle into the mesh, and therefore some degree of restabilization. There's also the multifidus muscle group in the spine, which is another mediator of core stability, which may undergo compensatory hypertrophy to again compensate for the divided transversus abdominis. And one question that I have is maybe these patients already had some degree of destabilization simply from having a hernia. And the abdominal wall doesn't get back to kind of a pre-injury state even after reconstruction. And that's something that is investigated a little bit in the other article by Jensen. So, the study has some limitations. It's a small sample size. The population has some characteristics that are fairly broad in nature. But improvements were seen in quality of life and back pain. So I do find it unlikely that there was an unmeasured significant decrease in core stability that was meaningful to patients. But I do wonder if there might be a subpopulation for which TAR could have a measurable impact on core stability. For example, someone who's a young and healthy athlete who has an accident, ultimately undergoes reconstruction and then is trying to get back to baseline. I don't think we really have the data to say either way. And the other, limitation of the study is that there isn't a comparator arm. So we don't have a population of hernia patients who underwent, say, a Reeves stopa where the transversus abdominis wasn't released. And we don't have a comparison group of people who are undergoing a first-time abdominal operation. But I do think, some takeaways from this, core stability and strength assessments, they offer some at least objective insight into abdominal wall function to go along with patient-reported outcomes. I think it would be useful to develop some consistent measures of core stability and strength for the purposes of research and quality improvement. And I think at least based on this article, that doing a hernia repair, restoring rectus muscles to midline, does appear to sort of offset the cost of muscle division. So I think I'll end it there. Any questions? Comments?
What do people think? So I will tell you, probably about 3 or 4 years ago, actually, I think it was at the QC retreat, like 3 or 4 years ago in Colorado, the last one before COVID started. I did something to my back, like didn't know what it was at the time. Turns out I did herniate a disc, and I was in excruciating pain, like it was brutality. And about a couple days later, I started getting like some foot drop and had some like lower extremity symptoms and stuff. And thankfully didn't need surgery, but I had to go to PT, and like PT was like, we need to work on your transversus abdominis strength. They were like, you have to get your transversus abdominis stronger. And I was like, I cut that all the time in the operating room. And the woman looked like I had like killed someone. She was like, that is horrible. Like, dude, please stop doing that. It's critically important for back pain. So it's really interesting that you guys found that back pain actually got seemingly better.
Well, I had a similar experience that actually is why we did this. Is I was a speaker actually in Australia right after a core physical therapist got up and basically gave a 20-minute talk that was so compelling about how important the transversus abdominis muscle is that I got up and showed everybody how to cut it. And I talked to her afterwards, and it really kind of made me pause and think, you know, I do think it's important just for like all of us to realize there are many things that we do that 15 to 20 years later, we learn the consequences of the hard way. So I think this paper was to look for like a gigantic signal, but like, you know, figuring out that there is a possibility that all the benefits of getting the midline closed might be balanced with people with chronic back pain. And I always, my example of that is just, you know, like when I was a kid, we used to radiate people for tonsils, and we caused papillary thyroid cancer that is now like fills our ORs with people taking it out every day. So I wouldn't underestimate the chance that this could be a bad idea. I think this paper, you know, I think we didn't see that, but I like what Sam said, which is so important, is this paper was in people with big defects. So perhaps the gain in bringing your anterior core back together offsets the issue with the back pain, but it should raise a concern that as we start to do TARs on much smaller defects, minimally invasively and things like that, that all of a sudden you might have younger, more functional people having multiple muscles cut that we don't know the long-term consequences of it. So I think it's a great comment, and I think that we should kind of always consider this. The problem is for big hernias, there's not a great way to fix it, but for doing it in the small hernias, which these people were not, the story might not be the same.
Yeah, I'd add a couple things. So out of all the papers that Mike's group has published, I actually think this is one of the most exciting, mainly because this gets to the concept and is probably one of 3 studies out there that shows that intervening in one part of kind of the cylinder idea of the core musculature has an impact on something else here, back pain. And to me, I think this is the future of hernia surgery. And, you know, we've spent the majority of the hour talking about how to fix holes. That's cool. And there's a lot of complex ways to do that. And we all have different ways of doing that. But I think you got to keep the end result in mind. The analogy I think of is our bariatric surgeons don't talk in terms anymore of weight loss over time. They talk about curing diabetes, curing hypertension, actually impacting their patients, not just with surrogate measures. I think that's where our field needs to head is let's fix the holes, but can we fix back pain? Can we reduce chronic constipation? Can we improve core stability? Can we improve pulmonary function? So for all the junior faculty and residents and fellows out there, I actually think this is the future where we need to invest a lot of time and effort. Because fixing holes is nice, but we got to prove that it does something besides just fix a hole.
And I would just add one thing to Ben. It also, we should make sure that it doesn't make another part of the cylinder worse. So I think looking at it as a whole, is things you do in the front can both hopefully positively, but potentially negatively affect the back and the sides, basically. And so I think that, you know, figuring all this stuff out is really important.
Dr. Petro had a good question. If we cut the muscle in this fashion, do we think we are reestablishing an insertion point of function?
Yeah, is there any like, I don't know, corollary to that where you can cut a muscle and it scars down, reestablishes an insertion point and can function again? Like, are we just assuming that the transversus abdominis after we cut it is never going to do anything ever again? Or
No, that's not what's happening when you cut the transversus abdominis muscle. Is you're not really cutting it off of anything. That's why nothing happens, right? Like if you think about it, you're not, when you do an external oblique release, you're taking it off the internal oblique and you're separating it. When we cut the transversus abdominis muscle, it's still completely attached to the internal oblique, and you're just cutting it to get to the peritoneum, and your plane is in the peritoneum. So that's why, to me, there is no release of the transversus abdominis off of the kind of anterior lateral muscles, like the internal oblique and the external oblique. It's still right there. You see it. So it's still actually inserted in the internal oblique. So I think that's quite frankly why we don't see it. And I think that when you really get down and talk with a physical therapist, you get to understand a lot of when they're considering the transversus abdominis is in spinal surgery, where if their approaches are cutting through anything, they're actually taking the insertion off of the bone, or the origin off of the bone. Our muscle at the end where we are, it's basically still inserted in the internal oblique. And that's kind of why it doesn't do anything for the anterior fascia, because it's right there. It didn't change. But I still think we need to figure that out more. And I would be cautious. And I would say that, like, you know, the effect on back pain and things like that for some of these misadventures like we've seen might be significant.
In the sake of time, I think I'll wrap things up. Thank you, everybody. Thank you, Dr. Greenberg, for moderating, and all of the faculty that helped with this. And of course, Luciano and Sam, y'all's presentations were awesome. Thank you. Next month, Dr. Mickey Reinhorn is going to be moderating an open inguinal hernia session where we'll talk about different approaches and options and the data behind that. And Megan is a resident at University of Toronto who will be helping present that, as well as Alex Lewis from University of Washington. So hope you guys join next month. Thank you, everybody, for joining and participating.
Great job, guys. Thanks
Thanks,
a lot.
everybody.